Hi, my name is Alexis Agdi. I'm Associate Professor of Medicine and Epidemiology at the University of Pennsylvania in Philadelphia. Today, I'm going to talk to you about sex differences in patients with psoriatic arthritis. This has been an increasingly a topic of increasing interest over the last several years, examining how men and women may have different outcomes and may present differently at baseline in patients with psoriatic arthritis. There's been so many papers about this recently that Laura Coates and I published a review article with our collaborators in the Journal of Rheumatology in 2022. In that paper, there's this nice figure that shows differences between men and women and kind of shows you a red dot if the women had a worse outcome and a gray dot if they were the same, and then a blue dot if men had worse outcomes. And you will see a lot of red dots. I think the story, the kind of bottom line of the differences is that women tend to have much higher disease activity levels, particularly with regard to patient-reported outcomes at baseline. And this includes pain, it includes fatigue, depression, general sensitization type of pain, health assessment questionnaire or physical function, as well as tender joint counts. Swollen joint counts tend to be quite similar between men and women, and the CRP tends to be more elevated in men compared to women. So across the board at baseline, women tend to look like they're doing worse. So then it's not surprising that after treatment in general, women also appear to be doing worse. So women are less likely to achieve minimal disease activity or low disease activity at follow-up after initiation of therapy. And this is true across multiple studies as well. But also true is that this is primarily driven by the patient-reported outcomes. Swollen joint counts tend to change similarly in those different studies. But pain, global, and physical function tend to still be worse at follow-up. Now, there might be multiple reasons for this. One is that there could be hormonal differences in how women process therapies, for example. There could be a contribution of postmenopausal women having more pain and fatigue at baseline, just as a part of a kind of that perimenopause or postmenopause. And maybe that there's less muscle mass, and maybe that has some impact on therapy receipt as well. We know that women tend to be on average more obese than men, and we definitely know that obesity has an association with diminished therapeutic response. There is more depression in women, and we see this across our studies as well. And that may be associated with more pain or central sensitization as well. So there's a lot of factors that could play into this, and we're still learning a lot about this. Leahy Eater is leading a new study in collaboration with GRAPPA called the SAGE study that will hopefully address many of these different aspects, particularly the hormone contribution and kind of differences in that fibromyalgia, central sensitization, and kind of depression aspects. So I hope that over the next 3 to 5 years, we'll have a lot more information about this particular topic. In the meantime, in terms of how we treat patients, I think, always thinking about what's most important to the patient, and that differs between men and women often. So, really getting a sense of what that patient's treatment goals may be and treating to those treatment goals, as well as our kind of general treat to target plan. Thanks so much for your attention today, and have a wonderful rest of the day.